Welcome to the first of 3 lectures on pediatric neuromuscular disorders. They're separated from the actual neurologic. The first one's going to address cerebral palsy. Cerebral palsy can result from a lot of different insults to the brain. What ends up happening is there is an encephalopathy that happens, and the child ends up with a chronic non-progressive disorder. As a result, they end up with impaired motor function because at some point they sustained a brain injury. And remember, we can have this prenatally, we can have it during delivery, and we can have it anytime after the child is born or any kind of injury that has caused trauma to the child. The particular motor area that is affected will determine the type of signs and symptoms that they have. And these are what we call the extrapyramidal areas. And they run down the spinal cord. And primarily they exhibit a lot of spasticity and stiffness. They're also awkward with their gait. And this cartoon actually is a good depiction of how some children with CP function when they need to actually perform activities. Now, mind you, there is a wide spectrum of CP. Some have just a little bit of tightness in their Achilles heel cords, and so they toe walk, but everything else is fine. And then we can go to the total opposite spectrum where they have severe spastic cerebral palsy and accompanying mental retardation, and they can barely even hold on to a spoon. So here's a couple of the causes. So prenatally, we can have blood group incompatibilities, we can have exposure to rubella, we can have twin-twin transfusion, there can be perinatal asphyxia, trauma, poorly controlled diabetes. Neonatally, these children can suffer from cerebral palsy because they have prematurity and they may have sustained an intraventricular hemorrhage, which is that IVH. They may be low birth weight, they might have been septic, or many other congenital anomalies. And then our infants and children who develop CP after delivery, long after delivery, is usually because they suffered from some type of an asphyxia event, including having a cardiopulmonary arrest. They might have been septic. Anything along those lines can cause the harm and lifelong CP. When we're doing an assessment, what we're looking for is their ability to feed. Do they have a good suck-swallow reflex? Are they thriving the way we expect them to? What's their muscle tone like? Are they tight when you go to put the t-shirt on or try and lift their legs or separate their legs to get the diaper on? Are they more irritable than you would expect them to be? And then do they have abnormal posturing? And I have a slide coming up where you can see what I'm talking about as far as some of the abnormal postures. That doesn't begin immediately. This is going to develop over time. Once this child is walking, what is their gait like? Are they broad-based, which is that ataxic gait? Do they have developmental delays? Are they meeting the gross motor developmental milestones the way they're supposed to? Some of the more severely affected children will have persistent infant reflexes. They may have accompanying seizures. So these are going side by side. CP is not causing the seizures. They just happen to have a seizure disorder in addition to CP. The same thing might happen with mental retardation. So when you're reading in the chart under current problems and it says MRCP, that means this child has mental retardation and cerebral palsy. There are some children who have mental retardation only, and there are other children who have cerebral palsy only. We have to distinguish between those categories. By far, the most common type is the spastic type. And if you were to do their DTRs, you would find that they're very brisk. They have hypertonic muscles and that are very tense, and it's hard for you to straighten their arms, straighten their leg, open their legs, open their arms, open up their fingers. They have a lot of flexion. That's how they keep their extremities. So we need to do the range of motion so that they maintain it. They might have jerking muscle contractions. And then when you watch them walk, they're tiptoe walking because of those heel cords. They may have what we call scissor leg movements, where they are crossing their legs side to side, and they're very difficult to get them to come back open. Eventually, they're going to develop contractures, and then seizures are fairly common. The different diagnostics that are going to be used will be the EEG. They may do an MRI, they may do a CT scan, and basically that's looking for some type of a reason why they're having the symptoms. Do they have a tumor? Do they have hydrocephalus that might be causing it? Because we want to find the cause and stop it so this kid can start progressing back on the path. They will get a very careful neurologic exam as well as a developmental assessment to see where they're at, how far behind they might be, and where we need to keep going to promote the best that they can be. And then, of course, nutritional screening is appropriate in those children who are failure to thrive, in addition to the CP. So here's an example of the posturing, and this is what we call apostotnik. So they are actually curved backwards. Instead of being in a nice fetal position, which is what we're used to in our position of comfort, these children are completely going the opposite direction. Here's another child on the right who has failure to thrive and has very tight muscles. It's hard to see, but look at this kid that's on the left. And this kid, he looks like he's got a lot of other problems, but this is what they look like with heel-toe, where they're just doing that toe walking. He's kind of doing that, but he certainly needs a lot of support. So the associated cognitive and psychological difficulties I've already mentioned about the mental retardation. There may be some degree of ADHD, some visual impairment that can be corrected, and communication difficulties, especially if we have the MR with the CP. There may be very limited communication. And for the mild CP kids, they can have an alteration in their psychosocial functioning because they have a chronic illness. There is a body image disturbance. And once again, if this kid never straightens their heel cord and they look very awkward when they're trying to do physical activity in front of others, then they get bullied.